All right, thanks for joining us on this panel session this morning as part of the Autistic Research Festival. The panel that we've got this morning is about physical health and basic science research about autistic people. And we've got a really good set of speakers here to speak today. And I'm just going to give a couple of quick instructions and housekeeping, and then I'm going to hand you over to Chris, who's our community chair for this session, who's going to say a few words. So the first thing is please make sure and use the Q&A function if you've got any questions for any of the panelists. We'll try our best to answer as many of those as possible, either in the Q&A session or throughout the talks. If you want to tweet alongside watching this, we would love to see you join the conversation on Twitter and try and make sure and use the Autistic Festival hashtag if you are tweeting. You'll also be able to follow along what other people are saying on that hashtag, or also by having a look at the responses to some of the Q&A questions that come in during the talk. We also have a code of conduct for this meeting, which is similar to the code of conduct for our in-person meetings. So even though you might not disagree with every word everyone says here, we do ask that you're respectful of people and different views, and we ask that you be kind to each other and accepting of differences of opinion and differences of views throughout the event. The event today is being recorded, so the video for this will be available on Autistic's YouTube channel after the festival finishes. So you'll be able to watch back if there's anything that you miss, or if you want to watch something again to get some more details about the talk. And that's something that will be made available with captions on the YouTube channel afterwards. So I'm going to hand over now to Chris Torrey, who's community chair for this session, who's going to introduce himself and introduce the panel for us today. Chris, would you?
Hello, I am Chris Torrey. As Lachlan has said, I am the community chair for this morning. I am involved with Autistica through one of the research groups, which is the Physical Health and Aging Study Group. I am also a nurse by background, primarily with a background in substance misuse, and I am also a network development manager for an organisation who support clinical staff working in homeless health. So my interests are, I guess, broadly speaking, health and autism. I'm autistic, and I think that's really me. So Lorcan's asked me to introduce the panel this morning. So I'm just going to quickly run through who everybody is and what they're going to talk about, which I believe is what I'm supposed to be doing. And then I'll hand back over to Lorcan. So this morning we've got 6 speakers altogether with a break after the first 3. Everyone will be speaking for about 15 minutes each. I really apologise if I mispronounce anybody's names. So the first speaker will be Lisa Quadt, who's talking about interoceptive training on anxiety in autistic adults. We then have Sarah Grant, who's talking about chronic illness and autism and central sensitivity syndrome. And we've then got Ozsivadjian, who is talking about cognitive inflexibility and which cognitive mechanisms predict internalising and externalising symptomatology. There's then a tea break. After the break, we've got Catherine Laverty talking about persistence and predictors of self-injurious behaviour in autism, followed by Gavin Stewart, who's talking about sleep problems and mental health difficulties in older adults. And then Helen Taylor, who's talking about barriers and facilitators to physical health care described by autistic adults and health professionals. So that's the morning, and I'm going to hand back over to Lorcan.
Brilliant, thanks Chris. Just as a recap for people who've just joined us in the last minute or two, there is a conference hashtag which is Autistic Festival. So if you're on Twitter, please do tweet along your thoughts or reactions to people's talks this morning. Also, please use the Q&A function on the bottom. So if you click Q&A, it'll bring up the option where you can submit questions. It'd be really helpful to us if you could submit these as questions rather than statements or comments, so that we can try and get as many of them answered by the panelists as possible. And just a reminder that, so we've got some links in the chat there for things that you might find useful or interesting throughout. Also, we wanted to take the opportunity to thank Fujitsu, our sponsor for the festival, who've made this possible. And just a reminder again that there is a code of conduct for this event, so please do be respectful of everyone's views. So I think we might just head over to our first speaker. So Lisa, can you turn your video on? Perfect. So if you want to share your screen, and the first talk, as Chris said, is Lisa Quadt, speaking about the impact of interoceptive training on anxiety in autistic adults, the Aligning Dimensions of Interoceptive Experience trial. Lisa is from Brighton and Sussex Medical School. Over to you.
All right. Yeah. All right, so thanks for having me, and thanks to Chris for doing the best pronunciation of my last name ever. I love Quadt, I will keep it. All right, so I'm a postdoc at the Neuroscience and Psychiatry Department at the Brighton and Sussex Medical School. And today I'm going to talk to you about our ADIE trial and its impact of interoceptive training on anxiety in autistic adults. And just as a heads up, I will talk about negative emotions like anxiety and depression in this talk. So just to give you a bit of background to why we did our trial, we know that autistic adults suffer much more often from mental health conditions than non-autistic adults. So previous research showed that depression is 4 times higher, loneliness is 4 times higher, and anxiety is at least twice as high in autistic adults than non-autistic adults. And we also know that up to 60% of autistic adults suffer from anxiety, which is quite a high number. So the standard treatment for anxiety, both in autistic and non-autistic adults, are cognitive behavioral therapy and selective serotonin reuptake inhibitors, which is just standard medication. But it is unfortunately questionable how successful these are. So I know from many of our autistic participants that come in that they thought neither of that really did do anything for them, have any effect, or were tailored to specific autistic needs. So it's good to see that there are novel treatments that are being explored. So on the Autistica website, you can find these tools that are being offered. There is a new trial coming out for personalized anxiety treatment, and another one that is just coming out for psychosocial treatments targeting anxiety and depression in autistics. And our ADIE therapy training is one of those novel treatments that we hope can give some autistic people a new and useful tool in their anti-anxiety toolbox. So ADIE stands for Aligning Dimensions of Interoceptive Experience. And I will now explain what this means, how we came up with the idea of this trial, how this trial exactly worked. And then I will also give you some teaser results from our trials, although we are still in the data analysis phase. It's a pre-registered randomized controlled trial, so we have to follow a specific protocol. So the data I'm going to show you is still quite preliminary. All right, so let's see what interoception is. So it is traditionally said that we have 5 senses: vision, hearing, smell, taste, touch. But these are senses that process the external world, what comes in from the outside. And we can distinguish this exteroception from proprioception, which is the sense of our bodies in space. So for example, even when you close your eyes, you will still know where your knees are. And then we have interoception, which is how we perceive and process internal signals coming from our bodies, like heartbeats or blood pressure or rumbling stomach. And to go into a bit more detail, body and brain are intrinsically coupled. So for example, whenever your heart beats, it sends a signal to your brain. And so our thoughts and feelings and behaviors are shaped by internal bodily signals. And in this way, interoception is connected to our emotions. So for example, when my dog sees her tail, her blood pressure might increase and she might feel anger as a result. Now, there are different ways that we can measure and distinguish different levels or dimensions of interoception. And one such model says that we can distinguish between accuracy, interoceptive sensibility, and interoceptive awareness. And I will now explain what all of this means. So for interoceptive accuracy, that means that we can measure objectively how precisely a person can sense their internal signals. And this is often measured by heartbeat detection tasks, although I have to give a little warning that these are under criticism and we are trying hard to develop better tools for that. But kind of the standard tasks are the heartbeat tracking task, where people are asked to count their heartbeats during a specific amount of time. And then we can compare how many heartbeats they actually had and how many they counted. And in the heartbeat discrimination task, people hear their heartbeat being played back to them in the form of like 10 tones. And they're played back either at the exact same time as their actual heartbeat or with a delay. And then the participant must determine whether the beeps they heard were at the same time or not at the same time as their actual heartbeat. For interoceptive sensibility, this is a measure of the subjective beliefs about how accurately people think they can feel their inner sensations. So for example, we can give them a questionnaire like this and use their score as a measure of this sensibility. So this questionnaire here, which is quite unpopular with the autistic community, and I apologize that we keep using it, it just kind of asks how often you feel these bodily sensations, like swallowing frequently or ringing in your ears or being exhausted. And lastly, we can compare this objective and subjective score for a measure of interoceptive awareness. And awareness here shows us the insight people have into their performance. So you can be accurate and you know you are, or you can be not accurate, but you think you're really accurate. You can be accurate, but you don't know that you are, or you're not accurate, but you know that you're not. So you have high insight here and not so much here. And now the findings here are very interesting. So we looked at both autistics and non-autistic adults and gave them the objective and subjective measure. And what these graphs here show us, oh, sorry, I forgot to, so this is this score for accuracy, and these are the scores for sensibility. So what this shows us is that non-autistic controls tend to be accurate, but they don't know it. But autistic adults tend to not be accurate, but have a very high score in sensibility. So they feel their bodily sensations on average all the time, but when you give them an objective task, they score rather low. So there seems to be a mismatch in autistic people between this objective and subjective measure. And the reason this is important is that we found that the bigger this mismatch gets, the higher the anxiety level of an autistic person gets. So this means that this mismatch predicts anxiety levels, which is what we see here on this graph, where anxiety grows bigger as the error signal, like this mismatch, gets larger. And this is what we are trying to change in our trial. So if we minimize this mismatch, do we also minimize anxiety? So these were our research questions. Like I said, we hypothesized that increasing interoceptive accuracy will reduce anxiety via aligning these dimensions of interoception. And our pre-registered research questions are: does improved interoceptive accuracy reduce anxiety symptoms in autistic adults? Which individual differences lead to the greatest benefit? So who benefits most, if anyone, from our therapy? And what are the potential mechanisms enabling this anxiety reduction via interoceptive accuracy enhancement? And this is what we did in our trial. So we had 121 autistic adults that we recruited. They were between the ages of 18 and 64. We had 57 who identified as male, 58 who identified as female, and we had 6 non-binary individuals. Most of them were verbal. We had some who speak few words. And our exclusion criteria were neurological conditions such as epilepsy and having psychotic experiences. And then when our participants first came in, we asked them to do a baseline assessment. So we gave them these 2 heartbeat detection tasks that I described earlier. We gave them the questionnaire for sensibility, and we also measured their state and trait anxiety. And state anxiety simply means the questionnaire asks about how anxious a person is feeling right now when they're filling out the questionnaire. And trait anxiety is how anxious they are in general in life. And then after that baseline assessment, they were randomly assigned to one of 2 groups. So they were either receiving interoceptive training or what we call prosody training, and both of which I'm going to explain in a minute. So we asked our participants to come in for 6 training sessions over 3 to 6 weeks, depending on their availability and whatever else was happening in their life. Now in the interoception training, we asked our participant to do the heartbeat tasks they did at the baseline assessment, but this time we gave them feedback about their performance. So say someone told the experimenter they counted 24 heartbeats, but they actually had 37. We told them that that was their actual score, so they got a better idea of their performance. Or if they told the experimenter that the tones were not at the same time with their heartbeat, we again told them whether they were right or not. And then after this first block, we asked them to do some exercise for 1 to 3 minutes, and they could choose whatever kind of exercise they wanted to do, run around our building, jumping up and down, going for a quick walk, whatever they could do and wanted to do. And we just wanted them to do that until they felt their heartbeat somewhere in their body. And then with that heightened awareness of their heartbeat, we did the same that we did in the first block, where they did the tasks with feedback, but this time it was a bit easier because they could actually feel their hearts in their bodies. So that was the interoception group. The people who got randomized into the prosody group, we played participants a sound sequence with someone saying a random sentence in different tones of voice. And then participants were asked to determine which emotion they saw on the screen was in that tone of voice. So I will play you an example, and I hope you will be able to hear it. Oops. No, it seems not to work. All right, so this person, if you could have heard it, you might have guessed that she sounded disgusted. And if you had got that right, you would have gotten a feedback, and it looks like everything crashed right here on my part.
Do you want to try unshare your screen and share it again?
Yeah, I am doing that, but it's going a bit slow. I apologize.
That's okay, take your time.
Okay, can you still see my screen?
Yes.
Okay, good. Then let me start.
It's gone now.
Okay, let me restart my presentation and then share. Sorry about that. I'm not going to try and play that audio file again because that seems to be not going so well for us. Okay. All right, can you see my screen again?
Yeah.
Great. Okay, so if you chose the right emotion that was in the tone of voice, you got feedback about that. Or if you were wrong, you were told what the right answer would have been. So that was our prosody training. And then after these 6 training sessions in either of the interoception or prosody group, we asked participants to fill out all the measures that they did in the baseline assessment so that we could compare them. And then we also asked them to come back for a 1-year follow-up, which is proving quite difficult in COVID times because we're not allowed to have participants, but we've now put it all online. So we will see, we're still doing that. Okay, so for the teaser results, the first thing that we are happy about is that accuracy for both tasks does improve significantly in our interoception group, but not in our prosody group. So people do get better at feeling the heartbeat and do get better at these tasks. The second thing we're happy about is that both trait and state anxiety does go down. It does go down in both groups, but more so in the interoception group, which is what we were expecting. And then what we also see is that the higher the change in anxiety, the more they changed in their accuracy score. So when people get more accurate, their anxiety drops. So we see that for trait anxiety, which is correlated with the tracking accuracy change score. And we see that for state anxiety with a C score, which is basically kind of a meta-awareness score. So again, this is what we're happy about and what we were expecting to see. And then we also have 2 subscales from the sensibility questionnaires for self-regulation and attention regulation. And again, the higher this score gets, the lower their anxiety goes. So again, we have a nice correlation there. And then we also asked people for some feedback, and we have some interesting statements. So one person said, as the inner channel gets clearer, the outer channel gets more quiet. So you can kind of see the senses as a seesaw, where the stronger the interoception from the inside gets, the less sensory overload they had. So another person said that when I notice the impacts of anxiety on my body, I am more aware of them and I'm able to reassure myself that it is just a physical reaction. I am better at taking deep breaths and trying to slow my breathing and heart rate down rather than letting it spiral. And another person said that I believe it has increased my awareness of hunger, and as a result, I remember to eat and drink and go to the toilet. So they report kind of a heightened, overall more precise awareness of their bodily signals. All right, so to conclude, going back to our research questions. Our first research questions was whether improved interoceptive accuracy reduces anxiety symptoms in autistic adults. And we think yes, we have some nice results that point to that, but we will have to wait for our final results to be able to say how much actually it will drop. For the second question, which individual differences will lead to the greatest benefit, we have to wait for our final results. And for the third question of what the potential underlying mechanisms are, we think that our preliminary data points to changes in self and attention regulation, but again, we will need more analysis. And then lastly, I want to thank especially our participants who came in so many times, up to 10 times to do our trials. So I really appreciate their time and all the feedback they have given us and everything I learned from them. I also want to thank the Actually Autistic Twitter community because I learned so much from them over the years. My mentors, Hugo Critchley and Sarah Garfinkel, and our PhD student on the trial, James Mulcahy. And that's it from me.
Fantastic, thank you, Lisa. That's absolutely fascinating study. We just have time for one clarification question, just because we're running a couple of minutes ahead. So somebody has asked, Catherine had asked, could you give a little explanation as to why the heartbeat task is criticized in the interoception literature?
Right, so for the heartbeat tracking task where you count your heartbeats, some people think that if you already know your beats per minute, say you have 60 heartbeats per minute, and you then are asked to count your heartbeats, you would kind of already know how fast or slow you have to count without actually feeling your internal signals. So the criticism is basically that these tasks don't measure pure interoception, but that they measure something else. And for the discrimination task, the criticism is that because it's basically a task of integrating a signal coming from the outside with a signal coming from the inside, it's more of a multi-sensory integration task than a pure interoception task. And I think we have to take these criticisms seriously. And the interoception community is working very hard to develop new tasks. But at the time we started the trial, these were really kind of the best we had. So we went with them, and I think our results show that there is something there that actually changes interoception, even though it might not be pure interoception.
Perfect. Thank you very much. Thanks again for a fascinating talk. Next up, we have Sarah Grant, who's a PhD researcher at the Institute of Psychology, Psychiatry and Neuroscience at King's College London, who's going to be talking to us today about chronic illness and autism and central sensitivity syndrome, symptoms and diagnosis in Dutch autistic adults. So Sarah, if you want to share your screen and turn your camera on.
Can you see my slides okay?
Yeah, we can see that perfectly. Thanks.
Great, okay. So hi, I'm Sarah. I'm a PhD researcher at King's College London, and I'm also autistic. And I'm going to talk to you today about chronic illness, symptoms and diagnoses in Dutch autistic adults. So physical health has historically received less attention than mental health in autism research, but health inequalities and co-occurring conditions have now been highlighted as a priority research area, so we're moving in the right direction. So looking more at autism and chronic illness, what we know so far is that autistic people experience more chronic disease and poorer health outcomes. We know that autistic people perceive and express pain differently. There is a common perception that autistic people feel less pain, but recent research has indicated that actually we might be more sensitive to pain than the general population. We also know that chronic pain conditions in children are often associated with undiagnosed neurodevelopmental conditions, and recent research into joint hypermobility syndromes has demonstrated that these are more common in the autistic and ADHD population, and these also come with chronic pain and fatigue. There are a number of frequently mentioned health conditions usually associated with pain and fatigue that seem to be associated with autism, but there hasn't been any research in autistic adults yet to determine whether this is definitely the case. These are called central sensitivity syndromes. So central sensitivity syndromes, or CSS, as I'll refer to them going forward, are a group of health conditions that are thought to have a process called central sensitization as a core component. Central sensitization is a state of hyper-responsiveness or overexcitability of the central nervous system. So it mainly refers to pain, including increased sensitivity to pain and experiencing pain from stimuli that are not normally painful, such as light touch. It's also associated with fatigue and heightened sensory sensitivity, such as to light, smell, and sound. Conditions falling under the CSS umbrella are much more commonly diagnosed in women than men. You might not be too familiar with this as a term, but you'll probably recognise some of the individual conditions. These are all considered to be a CSS in some of the research literature. You'll see fibromyalgia in there, ME or chronic fatigue syndrome, irritable bowel syndrome, migraine, restless leg syndrome, temporomandibular joint disorders or TMJ, and others as well. It's important to say here that you'd never receive a diagnosis of central sensitivity syndrome. It would be a diagnosis of one or often more of the conditions listed here. They often come together. CSS is just an umbrella term to describe the conditions as a group. They're often difficult to diagnose and symptoms can overlap. So in this study, we wanted to investigate whether autism and CSS are related by looking at how common CSS diagnoses and symptoms are in autistic people. To do this, we included participants from a longitudinal volunteer database called the Netherlands Autism Register. We had 982 autistic adults in total in this study, of which 563 were female, 409 male, and 9 identified as neither male nor female, so we've described them as trans or non-binary. People in the Netherlands Autism Register receive a questionnaire every year, so there was already data available on some things, such as sensory sensitivity and physical health. This also meant that we were able to avoid any recruitment bias. In addition to the standard questions in the register, we included a widely used measure of CSS symptoms called the Central Sensitization Inventory, or CSI, and we also included additional questions on comorbid conditions. So to tell you a bit more about the CSI, this measure was originally developed as a screening tool to establish whether someone might have a central sensitivity syndrome. It has 25 questions related to symptoms of CSS, and people indicate how often they experience that symptom. I've included a number of the items here so you can see examples. All of these symptoms might be experienced by any individual to some degree, so it's the combination and the degree to which they're experienced that is important. A score of 40 or more on this inventory, the CSI, is thought to indicate that someone is likely to have a CSS. So our hypotheses for this study were that CSS symptoms, so higher CSI scores, would be associated with more autistic traits, poorer mental health, greater sensory sensitivity because of the known link between CSS and sensory sensitivity, and poorer physical health and subjective well-being. We predicted that all of these effects would be greater for cis women than cis men, as we already know that CSS are more common in women. So on to our results. Firstly, we checked to make sure that CSI was a valid and reliable measure in this sample, as it had previously only been used with chronic pain in control groups. We did this using factor analysis and Cronbach's alpha, and this showed we could rely on the full CSI score as a unidimensional measure. So looking at gender and diagnosis, in this sample we found that women had more CSS diagnoses than men across the board, with those in the trans non-binary group not indicating any diagnoses. There were no males with a diagnosis of TMJ, and the higher rates of CSS in cis females are consistent with prior research showing that these conditions are more common in women. We then looked at the percentage of participants overall that had a CSS diagnosis. So here I need to say that we only included 5 of the conditions under the CSS umbrella: fibromyalgia, ME, TMJ, irritable bowel syndrome, and restless leg syndrome. So these are all conditions included in Part B of the CSI, the measure that we used. We found that 21% of our sample had a CSS diagnosis. We compared the prevalence rates in our sample with the approximate global prevalence rates in the general population. Our group had higher rates of ME and IBS than the general population, but we saw less fibromyalgia, TMJ, and restless legs than we expected. 21% might seem a high figure, but conditions like restless leg syndrome and IBS are quite common in the general population. So estimating prevalence can also be very difficult, as this varies by country and region, and it's affected by diagnostic criteria, clinician attitudes, and access to healthcare. So really we needed to look at CSS symptoms. So what about those? So CSS symptoms measured by the CSI are shown here, and 60% of the adults in this sample scored at or above the clinical cutoff of 40 on the CSI. So our mean score was 43.7. To give you an idea of the significance of this, the mean score in the control group during the development of the CSI was 21.55. So 43.7 is high. Autistic adults had lots of CSS symptoms. We then looked a bit more at gender and CSI scores, and we found that, as expected, cis women scored significantly higher on the CSI than men. In fact, they had a bigger effect on every measure. So women had more anxiety and depression, greater sensory sensitivity, poorer physical health, and lower subjective well-being. Our trans non-binary participants scored even higher on the CSI, but as we only had a small number of people in this group, there wasn't enough power to look at this properly, unfortunately. So moving on to the relationships between all of the variables, here are the correlations, and the significant relationships are starred. You can see that all of the relationships are significant. So we tried to look a bit more into how these might fit together, and a regression analysis indicated that the relationship between autistic traits and CSI score might be mediated. So we examined this using part analysis, which is a statistical method that examines structural relationships. In our model, we included CSS symptoms as an outcome, as these tend to develop later in life than autistic traits. We found that the relationship between autistic traits and CSS symptoms was fully mediated by sensory sensitivity and anxiety, i.e., anxiety and sensory sensitivity, which are both strongly related to autism, seem to explain the relationship between autistic traits and central sensitivity symptoms. I should also mention that gender was significantly related to every one of the measures shown here. So I should just say that path analysis in data that has been collected at one time point can never tell us enough about how relationships work over time. So this diagram is just theoretical. Longitudinal studies would be needed to test the model further, but it's a start in trying to pick these relationships apart. So what do these results tell us? Well, they imply that central sensitivity syndromes and symptoms seem to be common in autistic people. It seems that anxiety and sensory sensitivity are strongly associated with CSS symptoms, and they might explain why autistic people score higher on the CSI. But it also raises this question: why is it that so many of the autistic people with high CSI scores did not have a CSS diagnosis? So the results of this study show that there might be an association between autism and CSS, but I wanted to talk briefly about why this might be. There are lots of theoretical reasons. Some are listed in this diagram. Firstly, sensory sensitivity. This is a symptom common to both autism and central sensitivity syndromes. And one question we could ask is whether autistic sensory differences might make autistic people more likely to develop a CSS. So in this study, we looked at 5 sensory modalities, but other senses such as interoception are also likely to play a role. There are also high levels of stress, anxiety, and trauma in the autistic population, and these have all been linked with CSS in the research literature as well. A relationship could also be explained by common comorbid conditions, such as hypermobile EDS or Fragile X, and other common elements such as immune differences, inflammation, or autonomic function. Lastly, it could be the case that diagnostic criteria and diagnostic biases play a role in this as well. So just a few limitations to this study that I need to draw your attention to. So firstly, we didn't have a control group or a CSS only group, we just looked at autistic adults. We also only looked at 5 CSS that were listed in Part B of the CSI. Therefore, the number of people in this sample with a relevant diagnosis could have been higher than the figures shown. There's also the wording of the CSI to consider. This was a measure developed and designed to capture a broad array of CSS symptoms. So investigation using different measures and looking at specific CSS would be helpful. We didn't ask for CSS diagnosis method or dates in this sample. And lastly, the data is cross-sectional. So obviously further research is needed to build on this study's findings. Firstly, we need to know whether this association between autism, sensory sensitivity, anxiety, and CSS symptoms persists in other groups, for example, in controls and CSS groups. It would also be great to explore gender differences in more depth, particularly looking at how these relationships might affect trans and non-binary autistic people. We need research to see whether a CSS diagnosis might prevent or delay an autism diagnosis or vice versa. We need a qualitative exploration of the lived experience of autistic people with chronic illness. Longitudinal studies exploring the direction of associations would be great. Also, there are other factors to consider, such as camouflaging, how this might or might not contribute, and also how autistic burnout might relate to CSS, bearing in mind there can be a huge crossover in symptoms there. And lastly, as mentioned on my earlier slide, it could be the case that an association can be explained by comorbid conditions, and this needs to be explored further too. So here are some details about my collaborators, co-authors, and the funders of this study and the wider project, who I want to say thank you to. If you'd like to get in touch, I've also included some contact details here. Thanks.
Thank you very much for that really interesting talk, Sarah. I think really important to see this being addressed properly in the empirical literature, as it's definitely something autistic people have been talking about for quite a while now. So we're just going to move on to our next speaker, but please do submit questions, any questions you have for Sarah via the Q&A function on the bottom of your screens. And when we get to the Q&A after our next speaker, we'll be able to ask Sarah as many of those as we can as possible. So our next speaker is speaking on the role of cognitive flexibility, alexithymia, and intolerance of uncertainty in internalizing and externalizing difficulties in young people on the autism spectrum. And I think you've got your screen up already, so I'll pass over to you. Thanks.
Thank you. So my name is Ozsivadjian. I'm a clinical psychologist, and for 16 years I worked at the Evelina London Children's Hospital. And here is a list of the co-authors on the paper. I shall move straight on to the next slide. So yes, I'll be talking about the role of cognitive flexibility, alexithymia, and intolerance of uncertainty in internalizing and externalizing difficulties in young people on the autism spectrum. So just where we're at the moment is that we know much more. In terms of mental health, we know much more about anxiety and pathways to anxiety than we did about 10 years ago. I would say that we are currently still learning about depression, trauma, and suicide. And we're also learning a lot more about the mechanisms and factors implicated in internalizing difficulties such as anxiety and low mood, and also externalizing difficulties. There's not very much research really in terms of thinking about the mechanisms and pathways to externalizing difficulties in autism. So that's what we tried to capture in this piece of research. Intolerance of uncertainty refers to difficulties managing and tolerating uncertainty, and there's a substantial amount of research now looking at the role of intolerance of uncertainty in the development of anxiety in particular. So one piece of research has found that intolerance of uncertainty accounts for higher rates of anxiety in a group of autistic adults compared to young people, compared to non-autistic young people. Intolerance of uncertainty has also been shown to predict treatment outcome as well in another study. So there's some quite robust findings there in terms of the pathways via intolerance of uncertainty to internalizing difficulties, certainly in anxiety. There's also been a substantial amount of research on the role of alexithymia. So alexithymia refers to difficulties recognizing, labeling, processing your own emotions, differentiating your emotions from your bodily sensations, so quite relevant to the previous presentations, and focusing on inner rather than external experiences. And again, research has found that alexithymia can affect up to 50% of autistic adults, and it's also associated with higher levels of anxiety as well. But in one study looking at alexithymia and intolerance of uncertainty, by Meisel and colleagues, it was found that although in an initial model, intolerance of uncertainty predicted anxiety, when alexithymia was added in, this reduced the role of intolerance of uncertainty, and really alexithymia via intolerance of uncertainty tended to predict anxiety. And that really demonstrates that there are complex not necessarily linear pathways towards what we see, what presents clinically, such as anxiety, such as externalising difficulties. So what we wanted to do was investigate further some of these pathways, but we also wanted to focus on cognitive flexibility. And why did we want to do this? Well, it's been implicated in theoretical models, but massively under-investigated in the literature, yet it's a core feature, as it were, of autism. It's considered an aspect of executive functioning, so it's a tendency to focus on thoughts, behaviours and experiences to the exclusion of others, sometimes referred to as monotropism as well. It's a common feature of autism, so it's linked to highly focused, intense interests and repetitive behaviours. So as I mentioned, it's been implicated in models trying to understand the processes explaining anxiety in particular in autism, but as yet there's very little research evidence. It's also been associated with both anxiety and depression and aggressive and oppositional behaviours in autism, but just in 1 or 2 research studies. So as yet, it's received very little attention in the research literature. And we were hypothesizing how might cognitive flexibility affect internalizing and externalizing difficulties. And this really comes from our clinical observations. So, and also in the literature as well, people have hypothesized that, for example, reduced cognitive flexibility might lead to increased intolerance of uncertainty, for example, which in turn might lead to more anxiety. So, for example, if somebody isn't following the rules and you have quite a rigid expectation that people will follow rules, does that then create uncertainty about how the game is going to go? And then does that lead to anxiety? And then in turn, can anxiety lead to acting out or social problems or what have you? Or might reduced flexibility make it harder to use flexible or adaptive strategies to manage stress and anxiety? So in emotion regulation, we need to, for effective emotion regulation, we need to apply sort of cognitive strategies perhaps, or problem-solving strategies, and flexibility is really useful in terms of how effectively we can apply those strategies. And then of course this relationship could be bidirectional as well, in that the more anxious you're becoming, perhaps the more rigid you might become, less flexible, which might in turn affect your behaviour or affect your anxiety levels. So hopefully that demonstrates why we chose to focus on cognitive flexibility. And in terms of the study that I'm going to present now, no study has explored all 3 of the mechanisms together. So that's one thing that our study aims to do. And we also wanted to see whether cognitive flexibility, or in fact any of the other mechanisms, would predict both internalizing and externalizing behaviors, and to what extent. So our participants were a clinical sample of 95 young people, aged 5 to 18 years old, with a diagnosis of autism spectrum. There's 71% male in the population. The mean age was
I think Anne's Wi-Fi might have dropped out there. We're just going to wait for a moment to give her a chance to reconnect. Hi, Anne. Back. You're just still on mute there. If you just unmute. Yeah.
Am I unmuted now?
Yeah.
Okay, sorry about that.
That's okay.
So hopefully I would have got to the end of this slide describing our sample, and then I can talk about some of the measures that we used, which include the ARCADS, which hopefully most people will be familiar with, which is a commonly used scale looking at anxiety and depression as well. So internalising difficulties, we use a strengths and difficulties questionnaire, the emotional problems raw score, and also for externalising difficulties, we use the strengths and difficulties conduct problems raw score. And we also had a range of measures looking at the constructs that we were measuring, including the child Alexithymia measure, the intolerance of uncertainty scale, and the cognitive flexibility scale, the flexibility scale revised, looking at cognitive flexibility. And in terms of autism symptomatology, we use the DORBA routinely in our clinic, and we use the ASD module for that. Okay. So here are the results. So the first model that we explored looked at the relationship between autism symptoms and internalising and externalising difficulties.
We've lost Anne again. Just bear with us a moment. Just give Anne another minute to reconnect.
Apologies.
That's all right.
My Wi-Fi is letting me down here. It's been fine, absolutely fine. Absolutely fine. I think it's just overloaded a little bit on the system.
Yeah.
So
if you want to leave your webcam off, that might help.
Okay. Is it off now? I think it is off, isn't it?
It is off, yeah.
Okay, that might really help actually. Okay, so apologies. So let's just go back to the first model. So, as I was saying, the intolerance of uncertainty directly predicted internalising difficulties, but cognitive flexibility and alexithymia did not. However, cognitive inflexibility did predict externalising difficulties directly. And then in our second model, we looked at the relationship of autism and alexithymia and cognitive inflexibility via intolerance of uncertainty. And we found that cognitive inflexibility, as we know, directly predicted externalising difficulties, but also predicted internalising difficulties via intolerance of uncertainty. Which is interesting because it directly mapped onto the model predicted by Michael South and Jackie Rogers, where they looked at alexithymia and intolerance of uncertainty and in fact sensory sensitivities as well. And they predicted that these feed into anxiety and repetitive behaviours as well via intolerance of uncertainty. And that was very much supported by our models here as well. So just going back then to the discussion then. So of the three cognitive mechanisms examined, only cognitive flexibility predicted externalising behaviours directly. So we were thinking that flexible generation of alternative strategies, for example, maybe a more monotropic ways of thinking may make it more difficult to process difficult emotions, leading directly to more externalising behaviours. Cognitive flexibility also predicted internalising difficulties, but indirectly via intolerance of uncertainty. So, as I mentioned, this provides preliminary support for the model proposed by Jackie Rogers and Michael South, proposing that cognitive inflexibility may create an enhanced uncertainty, subsequently leading to more anxiety. So, in terms of implications for clinical practice, This may help us understand the emotional and behavioural difficulties which can sometimes be seen in autism by considering the underlying cognitive mechanisms. What leads to these difficulties, and could this help us to target our interventions more effectively? Intolerance of uncertainty, being a consistent predictor of internalising difficulties, for example, means that the importance of targeting intolerance of uncertainty focused type of symptoms using interventions such as the cues developed by Jackie Rogers and her group in Newcastle might be useful. And cognitive flexibility being implicated in both internalising and externalising difficulties means that possibly interventions targeting flexibility, for example, Unstuck and On Target, which is one developed by a group in the United States, and also cognitive remediation, which might be useful as well, which has been, it's an intervention that's been used quite successfully with eating disorders, for example. They may be really good either alternatives or supplements to cognitive behaviour therapy. And it may, the fact that rigidity or cognitive flexibility has been implicated quite so robustly, might it also explain why cognitive behaviour therapy may be challenging for some autistic young people? So for example, is it a barrier to cognitive restructuring, the element of CBT, where you try and help people identify difficult thinking patterns or styles which might be impeding progress? So ultimately, we think that any intervention would need to address both the underlying processes and social and environmental triggers or stressors or maintaining factors as well of presenting problems. And thank you, that's the end of my presentation. I hope that worked okay. Sorry about the difficulties.
Okay, that's great. Thanks, Anne. Sorry, I'm getting a bit of echo on my mic. Never mind. Just assume it's delay. So we're going to jump straight in to the Q&A, and there's a number of questions, so thanks everybody who has submitted questions. The first question is for Lisa, and it's from Matthew Belmont, and Matthew wonders, Lisa, I wonder how much your very interesting results on interoceptive training might have in common with mindfulness training, and might the techniques be acting via a common mechanism?
Yeah, that's a really good question. So first, anecdotally, we had 2 participants who were already masters at mindfulness. And one of them said that it didn't add much for them, our training, and one said that it added a nice bodily component that they didn't have before for mindfulness training. So there's definitely a connection there. And I think it can help with mindfulness to focus on your body like we train people to do. But I also hope that there's something unique about training kind of the interoceptive channel specifically, whereas mindfulness is probably a broader notion of being aware of what's going on in your mind and your head, where our training, we hope, can maybe help more like decatastrophize anxious thoughts via, oh, this is just my heart and it might be beating faster now because I'm anxious, but that's okay and I have techniques to calm it down. So there's definitely a connection. It's a really good question. But like I said, I do hope there's something unique about our training too.
Perfect, thanks. So the next question is for Sarah, and it's one that Sarah has typed an answer to, but I'm going to ask again for the purposes of people who haven't been following the chat. So Lucy Livingston said, fascinating thought, thank you. As the NIAR dataset is largely made up of autistic adults diagnosed in adulthood, do you think CSS symptoms may be elevated due to stresses or poor health related to late diagnosis?
Yeah, so like I mentioned in my answer to Lucy, I mean, it's certainly possible that that could play a role. So I mentioned in one of my slides that there's some research showing that particularly undiagnosed autistic and ADHD children often have chronic pain conditions, and the chronic pain is picked up before they are actually diagnosed. So it kind of runs that this might go into adulthood. So if someone's not diagnosed in childhood and goes all the way to adulthood without that diagnosis, maybe that would contribute. but it also could just be the case that these are symptoms that all autistic people have, whether they're diagnosed or not, that lots of us might experience chronic pain, and it's just part of the autistic experience that is not really being talked about before. It's difficult to say based on these preliminary investigations, but it's certainly something we hope to look at in future research.
Okay, great. Thanks very much. So the next question is for Anne, and it's from Alexandra Vold. And Alexandra asks, Anne, could it be that some people only exhibit cognitive inflexibility sometimes? And could it be a coping strategy of part of the brain when triggered?
Just unmute myself there. Yes, absolutely. I think all of these mechanisms, none of them are kind of fixed or set in stone. You know, for all of us as well, we all have traits which may become more prominent in certain situations or less prominent in certain situations. So I think inflexibility in particular is something that absolutely might be triggered in certain situations. And as I mentioned, there may also be this bi-directional relationship where certain situations increase inflexibility, which then feeds into anxiety or whatever other problems are presenting.
Yeah, that's really interesting to me in particular. As you know, my PhD was in executive function. So looking at anything that might be moving us towards interventions that might be able to target executive function is really
right. Okay.
The next question is from Carol Rivas, who's asked Lisa, does the impact of the ADIE persist into real-world activities? So she's commented particularly that the quotes that you provided from some of the participants in the trial talk about being able to be aware of hunger and things like that. So do you have any data from your trial that lets you know about whether it's having impact on those kind of real-world activities? And if so, is it showing that it does?
Right, so we do have a lot of questionnaire data. We do have an Alexithymia questionnaire, for example, and we see some changes there with the training. But again, we will have to wait for the final results. I think the most data we have on that is from the feedback that we get from our participants and from just anecdotal evidence that when people told us what they thought of the therapy, and a lot of them did say that they could transfer it to real world situations. I remember one participant telling me she tried it at the dentist and it made her a bit less afraid there. But we also had people that told us that they didn't really know how they would use it in the real world. So some people couldn't kind of translate it, or it just, wasn't the right thing for them. So we kind of have both, and in our final results, we will definitely address all of this. But it's a good question because we kind of, I think a successful therapy should translate into the real world.
Okay, great. This next question is for Anne, and it's from Annika. Oh, I assume it's for Anne, actually. It doesn't have a name to it, but it's with the Anne questions. And the question is, what do you define as internalized and externalized difficulties? So just some clarification around those terms.
Unmute myself there. So internalizing difficulties tends to refer to anxiety, low mood, that sort of thing. And externalizing difficulties tends to refer more to aggression, outbursts, meltdowns. So behaviours that you might see more readily, as opposed to distress that might be more internalised.
Thanks. Another question is quite a big one, I guess. The question is, how close are we for a possible treatment for cognitive inflexibility? Again, for Anne.
Well, as I mentioned, there's just two that I know of, really. Including the cognitive remediation that I mentioned. There's a really interesting therapeutic approach which involves sort of various mental exercises and tasks which are really thinking about thinking. So they're kind of neuropsychological tasks such as visual illusions and things like that. But I think the therapeutic angle is that once you've completed a task, you might ask questions like, what do you learn from this task? What does this say about your thinking style? How might this relate to real life? How would you apply this in the future? Kate Chanturi has done a lot of work on this in eating disorders as well. So I think it could be quite promising. And also the Unstuck and On Target programme that I mentioned, developed by, I think, Laura Kenworthy and John Strang, maybe some colleagues in the States. Again, that's a group intervention, trying to help young people think about how they can problem solve more effectively. So thinking about plan A's and plan B's, you know, what goes wrong if you consistently apply plan A and it's just not working? What other alternatives can you think of? So again, I think they could be quite nice adjuncts to traditional CBT, as well as possible alternatives if CBT just isn't having any effect at all.
Definitely, thanks. So I think as well as the Unstuck and On Target, which is for children, there's also the same group right now developing, I think it's called On Target for Life, which is the same idea for adolescents. So hopefully we're kind of getting to a point where there's going to be some options available that are appropriate for different age groups as well. That's really exciting, I think.
Okay, and there's a question for Lisa from Alexandra Vald again, it's a bit of a niche question in that you may not be able to answer it reading it, but Alexandra was wondering how interoceptive training differs from somatic therapies like somatic experiencing. I don't know if you understand enough about somatic experiencing to answer that. That's the question.
I'm afraid I don't.
Sure.
But we have developed this therapy together with expert on kind of neurofeedback and biofeedback, which is, I think, related to somatic experience therapy. But again, I would think that ours is kind of very specifically targeting this one stream from the heart to the brain, whereas I imagine that the other kinds of therapies are more like a broader somatic experience kind of treatment target.
Sure, just for the sake of definition from good old Wikipedia, somatic experiencing is a form of alternative therapy aimed at relieving the symptoms primarily of PTSD and other mental and physical trauma-related health problems by focusing on the client's perceived bodily sensations or somatic experiences. That's
good to know.
How it's defined.
Thanks. So the next one for Sarah is one that Sarah has answered already in the text, but I'm going to ask it again just for the purposes of people who haven't been following there. And the question is whether your CSS research is looking at non-epileptic seizures and functional neurological disorders as well.
Hi, yeah, so the research on central sensitivity syndromes, and that's an umbrella term, doesn't include non-epileptic seizures and functional neurological disorders, well, as far as I'm aware, but it might be that there's other research that has looked at that separately. So I'll definitely look into it, but the term tends to apply mainly to conditions like fibromyalgia and ME, where chronic pain and fatigue are sort of major components. And the non-epileptic seizures and the functional neurological disorder hasn't come up at all as far as I can see in the research so far. But that doesn't mean it shouldn't. So central sensitization is kind of a relatively new way of talking about all of these conditions together. So it could be that they will be linked in the future in other research.
Okay, thanks.
Okay, great. So this one's for Anne, and it's from Valentina, and it's another sort of definition query. So Valentina asks how you would distinguish between cognitive inflexibility and intolerance to uncertainty. So how are they sort of distinct, and I guess is there an overlap?
Yeah, that's a really good question, actually, because there is a huge overlap. It's one of the reasons why we wanted to investigate cognitive flexibility. The definition of intolerance of uncertainty, well, there's various definitions, but one includes the tendency to react negatively to uncertain situations and events. So there's something there particularly about the reaction, maybe something about the behavior or the emotional reaction to uncertainty. Whereas cognitive flexibility is more about the kind of a neuropsychological level, I suppose, process of focusing on your thoughts to the exclusion of all others, or following certain behavioral patterns to the exclusion of all others. And this can really affect how you effectively transition from one thought to another, or in fact one behavior to another. So when you think about in real life, you might actually have quite an extreme emotional reaction to something, but you might think yourself out of it, because you're kind of thinking, well, I could react in that way, but I'm actually going to react in this way. I'm choosing to react in this way, if that makes sense. But inflexibility can really hamper that process. So I think there's a huge overlap, but I can see, literally in clinical, presentations, how one can sort of impede the next, as it were. So, being less flexible can make you more intolerant of certain uncertain situations.
Fantastic, thanks. We're getting some really interesting questions here. So I'll ask one more and Chris will ask one more, and then we're going to take a break. But please do continue sending them in via the Q&A function, and we might get a chance to answer them throughout the second part of the panel. So the next question here is for Sarah, asking what research there is into the relationship between autism and Ehlers-Danlos syndrome, whether it's research, your own research, or whether there's anything else in the empirical literature that's informative about that.
Yeah, so my research doesn't cover this directly, but it keeps coming up as something that is comorbid between autism and conditions like fibromyalgia. So there's some research by Emily Casanova in the US, who has found a link between autism and the Ehlers-Danlos syndromes and hypermobility in women, in autistic adults. And there's also a bit of research by Sinibaldi looking at how hypermobility is linked to autism and ADHD in children. There's also someone called Jessica Eccles at the University of Sussex who works with Lisa, I think, Lisa will know her, who is doing research on EDS and hypermobility, and she also has looked recently at fibromyalgia in conjunction with Ehlers-Danlos syndrome and also anxiety as well. So I think that she's probably going to end up going in that direction too, looking at autism and EDS. So there is quite a bit of work starting to happen on this, but it is a relatively new field, and I felt it was important to mention it because with fibromyalgia particularly, a lot of the time it can be that hypermobility and joint hypermobility actually underlies some of that chronic pain, and there have been cases of people being diagnosed with fibromyalgia that actually turn out to have these hypermobility syndromes. So I hope that's helpful in pointing you in the right direction. But in the UK data that we're collected as well, we have actually asked a question about EDS to try and capture whether that is an underlying thing here as well. In the Dutch autistic adults, we didn't have that as a question, so I'm afraid I can't speak for whether that's a factor there. But yeah, I hope that's helpful anyway.
Great, thank you. And the last question, I'm actually just going to say online, before I ask this question, there's a couple of queries that have come in about technical quality and being able to watch things later. As we've highlighted, everything will be available on YouTube after we finished sort of downloading it and so on. The final question, Matthew asks Anne, might the effect of cognitive inflexibility on externalising be an issue of perspective taking in particular?
Absolutely. One of the reasons I became interested in investigating cognitive flexibility was observations during treatment. And obviously in CBT, you're asking a lot of questions about, things that happened, what were you thinking, what might someone else have been thinking? And perspective taking is a really key role in that, actually. And inflexibility in terms of considering alternative perspectives, again, can impede progress. And also, yeah, that's a very valid point, that it could really result in externalizing difficulties if you're becoming quite angry about something, or very, very anxious about something, because you maybe misinterpreted a situation, and you haven't developed flexible ways of thinking about things differently, then yeah, absolutely, that's a very valid possible pathway.
All right, thank you very much. And I think that's a good point to send a massive thank you to Sarah, Lisa, and Anne for a really interesting first part of this panel. We're going to take a quick tea break until 11:30. So if you want to pop off and have a comfort break and come back at 11:30, and we'll start for the second half of the session.